Good evening and a very warm welcome to good morning and a very warm welcome to everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, who is present here with us today. So let us together welcome the very renowned Dr. Amit Dravid, sir. Sir is MBBS, MD in Internal Medicine, Chief Consultant in HIV Medicine and Infectious Disease at Ruby Hall Clinic, Noble Hospital, Pune Hospital, and Medical Research Center in Pune. With Sir's wonderful insights and his enriching experience, we are going to talk about the topic for today, which is what are the recent updates on HIV in 2023. Before moving on to today's session, let's have a brief look on what the topic says. So, we'll be having an insightful webinar as we explore the cutting edge developments in the field of HIV research and treatment in 2023. This webinar aims to provide healthcare professionals, researchers, and the community with a comprehensive overview of the recent updates and breakthroughs in the ongoing fight against HIV. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin.
Yeah.
So, over to you.
Thank you, Ankana. Thank you, Batul from IJCP. Can you hear me?
Yes, sir, you're audible. Please
Yeah.
continue.
Yeah. So the topic given to me today for this webinar is recent updates in the management of HIV in 2023. And there have been multiple updates, and over the next 35 to 40 minutes, I will tell the audience where we are as regards to HIV management in 2023. So here we go. As you all know, we have come a long way in giving antiretroviral therapy to almost everybody now. So today, ART for all is the mantra. We started in 2003 with ART to be started only when the CD4 count falls to less than 200. Then it went to the threshold for starting antiretroviral therapy, went to a CD4 threshold of 350, then 500. And now we are now in the era of test and treat. So every patient who walks into your OPD today, who is found to be HIV positive and has no symptoms of any opportunistic infection, when he sits in your OPD, we can start antiretroviral therapy immediately on the same day when he comes into your OPD. So you don't need to wait. We can start antiretroviral therapy immediately. That is where we are as of today. Why are we starting antiretroviral therapy early, irrespective of CD4 count? Whether the CD4 count is 200, 500, 1000, doesn't matter, because WHO and UNAIDS have now given us a target of 90-90-90. India also has to achieve this 90-90-90 target. What is 90-90-90? That means India has to identify 90% of its HIV epidemic. So out of the 22 lakh, we have to identify 20 lakh by 2020 was the target. We have already missed it. So we have to achieve it as early as possible. Out of the 90% who are diagnosed, 90% should be immediately put on treatment. And out of those put on treatment, 90% have to be virologically suppressed. So if you look at the overall picture, if we identify 20 lakh patients of HIV in India as fast as we can and put everybody of them on treatment, around 72% should be virologically suppressed. That is the only way we can stop new infections of HIV happening in India. So that is why if we want to end the AIDS epidemic, I'm not saying the HIV epidemic, but if you want to end the AIDS epidemic, you want to reduce the incidence of HIV in India to the lowest range possible, then India has to achieve this 90-90-90 target. What happened in 2022? Botswana, a small country in Africa, reached the target of not just 90-90-90, but 95-95-95. This was seen as a huge success story because in Botswana, 95% of the persons know their status, out of which 95% are on treatment and out of which 95% are suppressed on treatment. Not just that, 95% of the women have access to sexual and reproductive health services in HIV, and 95% coverage of services in preventing vertical transmission of HIV has also been achieved. So in 2022, a small African country, or impoverished African country of Botswana, achieved 95, 95, 95. So forget the West, even the African countries are achieving 95, 95, 95. In 2023, there are few more countries from Africa who reached the 95, 95, 95 target. Botswana achieved it, Rwanda achieved it, Tanzania achieved it, Zimbabwe achieved it. So one must say, along with the West, few African countries have also achieved 95, 95, 95. So where is India? Look at the lowermost slide over here, the lowermost row. In India, in 2021, we have identified 77% of the epidemic, out of which we have put 84% on treatment, out of which 85% are virologically suppressed. So if you look at it overall, around 55 to 60% of our HIV positive population is suppressed. That's it. So we are a long way away from 95, 95, 95. If we say that we are going to become the third largest economy in the world, and we are going to become an economic superpower, then this is the statistic which has to change fast, because impoverished African countries are reaching there faster than us. It requires a lot of commitment to reach 95, 95, 95. We are still stuck in 2021 at 77, 85, 85. So long way to go. We have to take huge strides. Then we come to guidelines. What are the guidelines currently saying? WHO modified its guidelines in 2019 when dolutegravir was introduced into the free ART sector and also into the private sector. And it was very clear that dolutegravir plus two nucleoside reverse transcriptase inhibitors, mostly tenofovir and lamivudine, are going to be the drugs of choice. In the last 5 years, these guidelines have not changed. So tenofovir, lamivudine, dolutegravir, fixed dose combination, single pill is now the treatment of choice as first line given in free ART sector, which caters to almost 80 to 85% of the population, and the private sector, which caters to around 15 to 20% of the HIV positive population in India. So almost more than 95% of people are getting TLD as first line antiretroviral therapy, single pill, which they have to take lifelong. What is the alternate regimen which is there? It is tenofovir, lamivudine, and low dose efavirenz, that is efavirenz 400. So we are no longer using the TLE 600, which we were using 5 to 6 years back. We have realized that by reducing the dose of efavirenz to 400, we are achieving the same amount of virologic suppression, and also we are achieving much lesser side effects than we had because of TLE 600. Those who are using efavirenz 600 will know that patients used to complain of dizziness, of loss of concentration, inability to concentrate, inability to drive, nervousness, depression. All these symptoms are reduced, not completely gone, but reduced to a large extent once you use TLE 400. So now, according to guidelines, TLD is the first line and TLE 400 is the alternate second line regimen, which everyone in India must use. Majority of them are already using in various sectors in India. What do the Americans say? The Americans have multiple other regimens as well. In India, TLD and TLE 400 are the regimens available, while the Americans are also using TAF, FTC, bictegravir, which is another single tablet which is now available in India as a preferred regimen as well. So in India also there are three regimens: TLD, TLE 400 as alternative, and now TAF, FTC, BIC as a single tablet regimen, which is also recommended by the Americans. So three tablets are there which are now as first line therapy, can be used, out of which only TLD is available in the free ART sector. TLE 400 and TAF, FTC, bictegravir are not available in the free ART sector but are available in the private sector. So in the free ART sector or the government sector, one tablet for first line, while in the private sector, three choices for first line for HIV positive population in India. So what do you think in the future the antiretroviral regimens will look like? Already we have been ingrained in our mind that we require three drug combinations, triple drug combination, combined into a single pill, which has to be taken daily. What do you think over the next 5 years the first line ART regimens will look like? The data which is getting published in 2023 clearly suggests that the first line regimens will look much, much different than what they are looking like today. Whether we will be using TLD in the future, whether we will be using TLE 400 in the future, whether we will be using TAF FTC BIC in the future, we don't know. And why is it so? Because there have been now multiple trials which have published with dolutegravir as the backbone, where it has been shown that even two drug regimens are doing as good as three drug regimens in maintenance first line therapy. And I'll show you how. This was the first trial, which was the Gemini trial, which was published, and it showed that if you use TLD, tenofovir lamivudine dolutegravir as first line, versus only dolutegravir lamivudine as first line, single pill. And we also have dolutegravir lamivudine single pill in India. MCure has brought it out, which is known as Twinact. So we do have Twinact in our Indian setting as well. So what they did was they looked at ART naive individuals whose viral load was less than 5 lakh, had never been exposed to any antiretroviral therapy, and they looked at it head to head in comparison with TLD. So these patients were ART naive, newly diagnosed HIV, viral load less than 5 lakh, CD4 could be anything, were put on, half of the patients were put on TLD, half of the patients were put on only dolutegravir lamivudine. And to their utter surprise, they found that at 3 years, virologic suppression with dolutegravir lamivudine was equivalent or non-inferior to TLD. So, a two-drug regimen in patients who are ART naive with viral load less than 5 lakh was doing as good as TLD. And which is a revelation because almost 95% of the patients who follow up in our OPD for first line have a viral load of less than 5 lakh. We don't do a viral load at baseline, but if we indeed do it, we will find that 95% of the patients have a viral load less than 5 lakh. Is this the ultimate gospel truth? No. Once you use two drug regimens, we know that tenofovir is required for hepatitis B. So hepatitis B co-infected patients cannot be given a two drug regimen. But yes, hepatitis B co-infection in Indian setting with HIV is only 3%. So in majority of the population, this regimen can be used. It has still not been recommended to use by the government of India or by ICMR, but there is clear data to put out that if you are ARV naive and your viral load is less than 5 lakh, then even a two drug regimen is equivalent to a three drug regimen, provided dolutegravir is a backbone in that regimen. No other regimen can be used this way. And what are the advantages? You know, tenofovir is a nephrotoxic drug. It is a bone toxic drug. It causes osteopenia. Sometimes it causes osteoporosis as the treatment goes on and on for a longer time. Also, the kidney markers will start increasing. It causes Fanconi syndrome. It causes proximal tubular toxicity. All this can be prevented. So the toxicity can be prevented and the efficacy can be kept the same if you use a two drug regimen instead of a three drug regimen. Whether instead of using upfront, we can use it as a maintenance therapy. That means you give three drug regimen upfront, suppress the viral load in ARV naive patients. Once the viral load is suppressed, then shift to a two drug regimen. So you get the advantages of a three drug regimen and also the advantages of a two drug regimen. Whether that can be done, this was the Tango study which was published in CID very recently, and they found that once you are suppressed on a three drug regimen, it can be any three drug regimen. It can be TLE 600, it can be TLE 400, it can be TLD, it can be tenofovir lamivudine plus a protease inhibitor as first line. Once you are suppressed, then you can shift to just dolutegravir 3TC as second line, as first line, provided you are hepatitis B negative. And if you compare it head to head to continuing three drug regimen, then the virologic efficacy remains the same. You can see two drug regimen is achieving virologic suppression is almost 93% of patients at 1 year. So it has robust data which has proven that if you are ARV naive, you have no exposure to antiretroviral therapy earlier. Once you are put on three drug regimen, which can be any three drug regimen, it can be TLE, TLE 400, TLD, TL plus protease inhibitor, and you are virologically suppressed, you can be easily shifted to a two drug regimen of dolutegravir lamivudine first line once you are proven that your hepatitis B negative, and then once you continue two drugs, then suppression is achieved at 48 weeks. So not just upfront, even in maintenance therapy, dolutegravir lamivudine is doing just fine. And you can see here, non-inferiority has been maintained against a TAF-based 3-drug regimen. So it's a very, very good regimen. Then there are other 2 drugs which can be used, not just dolutegravir lamivudine. In the West, dolutegravir rilpivirine. Rilpivirine is a sister drug of nevirapine. It's an NNRTI. It also has a long half-life, just like dolutegravir. And the dose is only 25 milligrams. So 50 milligram dolutegravir, 25 milligram rilpivirine have been combined into a single pill and has been used as a first line upfront single tablet regimen in patients who are hepatitis B negative, who are ARV naive, and are just HIV positive. This SWORD study has been published in the Lancet, and it has shown that those who are ARV naive, if they are put on TLD versus just dolutegravir plus rilpivirine, have equivalent virologic success rates. So you can see we are moving to an era where 2-drug antiretroviral therapy regimens with dolutegravir as the backbone is going to become a reality. It can be used upfront, provided you are HbA1c negative and your viral load is less than 5 lakh, or it can be used as maintenance therapy once your virological is suppressed on any first-line antiretroviral therapy and you are hepatitis B negative, or if dolutegravir rilpivirine comes to India, then this will be a novel first line, which will be just the smallest pill available, just 75 milligram for upfront use in ARV naive patients who are hepatitis B negative. So across CD4s, across viral loads, dolutegravir rilpivirine is doing as good as any 3-drug regimen. Then are we happy with just tablets? More and more patients are now coming to me in our OPD and saying, sir, we are tired of taking these tablets. Patients are on antiretroviral therapy for 10 years, 12 years. Even by shifting it to 2-drug regimen, they say that the tablets will still remain. I'll have to keep taking 1 tablet a day. How long are we going to keep taking these tablets? So the answer to this is here. We now have the first injectable antiretroviral regimen available in the West. Entire America, Europe, and Australia has now shifted to this injectable antiretroviral regimen, which contains 2 drugs. Again, instead of dolutegravir rilpivirine as a tablet, we now have a long-acting integrase inhibitor, which is cabotegravir and rilpivirine, as an injection. And this study was published in the Lancet, in NEJM, about whether it can be a good maintenance regimen. What did they do? They took patients who were on first line and were suppressed on any protease inhibitor, NNRTI, or integrase inhibitor based regimen. On first line, never having any resistance mutations to any antiretroviral earlier. Once they were suppressed, they shifted them by continuing the same regimen, half of the patients, or shifted them to long-acting cabotegravir rilpivirine monthly injections. And what they found was, you can see here, even if you continue oral therapy or you shift to injectable therapy, 93% of the patients are still virologically suppressed at 1 year. So by shifting, we can guarantee the patients that you will become tablet free. You will just take 1 injection once a month, and you have to take 12 injections in a year. And after 1 year, we promise you that if you are suppressed at the start on any antiretroviral therapy, there is a 93% chance that you will be suppressed at 1 year, and with minimal adverse events. The major adverse events are injection site reactions, but 98% of the injection site reactions are grade 1 or 2. They do not cause discontinuation of the injection. So we are gradually entering into the long-term injection era of HIV, where maybe 2 years down the line, are patients who are suppressed on first-line antiretroviral therapy and who are HbA1c negative will be tablet-free and will be shifted to an injection, which is cabotegravir, long-acting cabotegravir rilpivirine injection. So 400 milligram of cabotegravir, 200 milligram of rilpivirine once a month is the first Atlas trial which was published, which shows that the maintenance is suppression is maintained and you don't require to change the therapy. So this was published in NEJM. You can see here long-acting cabotegravir rilpivirine every 4 weeks. You can see the virologic failure rate is only 1.6%. And even if you fail, you can still be suppressed with a dolutegravir or a PI-based regimen. And the adverse events are only 1%. So we can guarantee to our patients that you will become tablet-free very soon you will be on injections containing only 2 drugs very soon, and it can be taken monthly. So you can just take 12 injections in a year and just be rest assured that you will be virologically suppressed. We then further improved this injection, and we decided that whether we can give this injection as a 600, 300, 2 monthly injection. So 600 milligram of cabotegravir, 300 milligram of rilpivirine once in 2 months. So just 6 injections in a year instead of 12. And it was found that even 6 injections in the year do as good as 12 injections in a year. Pardon me, the dose is 600 milligram of cabotegravir, 900 milligram of rilpivirine for once in 2 months injection, while it is 400 milligram of cabotegravir, 600 milligram of rilpivirine once in 4 weeks of injection. And we found that even if we give a larger dose every 8 weeks, the virologic suppression is maintained. The adverse events are very, very low. So very soon, maybe next year, we can tell our patients that you will become tablet free and you will just be having 6 injections once in 2 months, an injection for a year, and you will be virologically suppressed. The only caveat, you should be suppressed first with some first line antiretroviral therapy, and you should be HBsAg negative. These two criteria are fulfilled, then we can shift you to an injectable regimen. Adverse events, injection site reactions, most common, but again, 98% injection site reactions are grade 1 or 2. They can be easily taken care of by giving antipyretics like paracetamol or maybe an anti-allergic medication. Nothing else needs to be done. So study after study has shown that many, many more patients who are on first line antiretroviral therapy want to shift to an injectable cabotegravir rilpivirine regimen. People are tired and saying that daily HIV medication is inconvenient. I have to hide this HIV medication from others and take it. It keeps reminding me about my HIV status and leads to quarrels or tiffs at home. And so many, many patients, if you ask in your OPD as well, many patients will be willing to shift to cabotegravir rilpivirine. Time has come where cabotegravir rilpivirine should be introduced in India, although the cost has to be controlled, and very, very soon Indian patients also need to go on a first line maintenance 2 drug injectable therapy regimen. Then they said that if it is seen in first line maintenance regimen, can we use it in patients who are not very adherent? So which are these patients? Everybody in their clinic has patients who are not going to take treatment regularly, who always keep on missing their tablets. Which are these patients? Those who have unstable housing, those who are homeless, have major mental illness, or who are alcoholics, or who have stimulant abuse, or don't have insurance. All these patients were taken into San Francisco. This study was known as the Ward 86 study. They took 133 patients who were not adherent on their first line antiretroviral regimen and told them that why don't you shift to cabotegravir rilpivirine? And they found that in these patients who were homeless, who had unstable housing, who had stimulant abuse, who had mental illness, by switching to cabotegravir rilpivirine and by telling them that you don't need to take tablets anymore, almost 100% of suppression was achieved. Even in those patients who were viremic, almost 98% of suppression was achieved. So especially in those patients who follow up in your OPD where you're confident that this patient won't be able to take oral antiretroviral therapy, oral tablets regularly, shifting to injectable cabotegravir rilpivirine is a good job, and studies have shown that it is useful. Similarly, can you shift from TAF FTC big to cabotegravir rilpivirine? You know that TAF FTC bictegravir is available in India, and now these studies have shown that you can even shift from dolutegravir to cabotegravir injectable. You can shift from bictegravir also to cabotegravir injectable and maintain the virologic suppression at 1 year. So it is a very, very good regimen. Very soon, maybe by as early as next year, because I know that almost 3 companies in India have got licenses for injectable cabotegravir rilpivirine to be rolled out. Hopefully next year we will have once monthly or twice monthly injections, 2 drug regimens for first line maintenance therapy in Indian patients as well. Now we move to first line ART failure. What is new in patients who have failed first line antiretroviral therapy or those who are on second line antiretroviral therapy? So this dawning study was published in 2020. It was very simple study. You know that initially when the patients used to fail zidovudin, lamivudin, nevirapine or tenofovir, lamivudin, efavirenz, we used to shift them to a protease inhibitor, either atazanavir or lopinavir plus a new NRTI. Whether if tenofovir was used in first line, we used to use zidovudin in second line. If zidovudin was used in first line, we used tenofovir in second line. So this study compared whether we can use dolutegravir plus two new NRTIs in a patient who is failing on efavirenz or nevirapine versus lopinavir ritonavir, which was our standard second line. And it was clearly seen that if your patient is failing ZLN, if your patient is failing TLE, then shifting to dolutegravir plus two new NRTIs is more beneficial, is superior to shifting to lopinavir plus two NRTIs. So dolutegravir had outperformed lopinavir in this study, because of which the new guidelines, WHO guidelines, which are now followed in free ART sectors in India and in private sector, also said that dolutegravir should be the backbone for second line. So in India now, dolutegravir is the backbone for first line in combination with tenofovir lamivudine, and dolutegravir is the backbone for second line in combination with two new NRTIs. So WHO and the Indian government and ICMR is and NACO is clear that if you have used efavirenz in first line, then you shift to dolutegravir in second line. And if you have AZT3TC or zidovudin lamivudine used in first line, you shift to tenofovir lamivudine dolutegravir in second line. If you have used tenofovir lamivudine efavirenz in first line, you shift to zidovudin lamivudine dolutegravir in second line. Atazanavir and lopinavir, which were our prime protease inhibitors, have been shifted to alternate second line regimens. But is it true? Do we have to continuously keep using dolutegravir, tenofovir in second line? No. This was the Nadia study, which was published in NEJM. It was a very simple study which showed that if you are failing tenofovir plus NNRTI, then whether to give dolutegravir or darunavir as a backbone. Remember, dolutegravir was compared to atazanavir, was found to be superior. Dolutegravir was found superior to lopinavir. Yes, it was found to be superior. But now in India also, we have darunavir ritonavir as a very potent protease inhibitor. So what did the Nadia study do? All those patients who were suffering or were failing on TLE, they shifted to dolutegravir or darunavir, and they made four categories. You shift to tenofovir lamivudine dolutegravir as second line, or you shift to zidovudin lamivudine dolutegravir as second line, or you shift to tenofovir lamivudine darunavir as second line, or you shift to zidovudin lamivudine dolutegravir as darunavir as second line. And what they found was that darunavir and dolutegravir are virologically equivalent. You can see here, whether you shift to dolutegravir or whether you shift to darunavir doesn't make a difference. Virologic success is maintained in all the patients. Almost 90% of the patients, virologic success is maintained. Similarly, whether you shift to tenofovir or zidovudin doesn't make a difference. So even if you are failing on TLE and you shift to TLD in second line, almost 92% of the patients are virologically suppressed. So this whole idea that if I am failing on TLE, I have to give zidovudin in second line is completely passé now. This trial has proven that you don't need to shift from TLE in first line to ZLD in second line. You can just carry forward the TL into the second line. Although if K65R or M184V mutations are there, still tenofovir will work. So this whole idea of genotypic resistance testing guiding our second line regimen should be stopped now. Even if the tenofovir is partially resistant or completely resistant, even if you have no NRTIs working in second line, still when combined with dolutegravir or darunavir, the regimen will work, and the second line regimen will suppress almost 90 to 92% of your patients. So Nadia study is very clear. If you fail TLE, shift to TLD, no problem. If you fail TLD, you can shift to TL darunavir and still achieve virologic suppression. So zidovudin for second line is really not needed. You know zidovudin has to be given twice a day. You also know that zidovudin has side effects like anemia. So we can just skip it and shift to tenofovir in second line as well. So tenofovir can be continued from first line into second line. Dolutegravir and darunavir can be the backbone for treatment. So the next question is, we know how first line regimens will look. We know how second line regimens will look. So how will the PrEP regimens look? And you know that PrEP has picked up in a huge way in India, especially amongst the men who have sex with men community, where they are at very high risk of incident HIV infection. And hence we give oral PrEP, tenofovir FTC, to all those young vulnerable men who are at high risk of infection, especially those who practice insertive anal intercourse and in whom usage of condoms can be erratic. So their PrEP regimens are being used. It has also been advocated in transgender men, transgender women, and even in prostitutes who cannot guarantee usage of condoms. So how will it look initially? As of now, we are using tenofovir emtricitabine or tenofovir lamivudine as the preferred PrEP regimen, where we give them this regimen and ask them to take one tablet every day lifelong, as long as they are practicing risky sexual behavior. But again, there is fatigue associated with oral tablets. Many times it has been shown that the success of the PrEP regimen depends upon how well you take it, how adherent you are. And study after study has shown that if you are using oral tenofovir emtricitabine as your PrEP regimen, pre-exposure prophylaxis regimen, then the patient has to ensure that he has to take 6 doses at least per week. So out of 7 doses per week, or 1 dose per day, he has to end up taking 6 doses per week if he really has to protect himself from incident HIV infections. And sometimes in patients who are HIV negative, having this level of adherence is sometimes difficult, because patient says, I am not suffering from HIV. Why do I have to take a pill to protect myself? Can't I do anything better? So this NEGM's trial came out where they used, again, not just IM cabotegravir as PrEP regimen. And you can see here, what they did was they give 600 milligram intramuscular cabotegravir once every 8 weeks and compared that versus daily oral TDF FTC and as PrEP regimen. And you can see here, TDF FTC was associated with almost 80% more incident HIV infections. They used this in a population which was at very high risk of HIV infection, especially transgender men, transgender women, who used to practice insertive anal intercourse and whom condom usage was erratic. In such patients, you can see by giving injectable cabotegravir, only single drug, there two drugs are not needed. Cabotegravir rilpivirine is used for treatment, while only IM cabotegravir is used for PrEP regimens. And you can see here, the lowest amount of exposure or lowest amount of sexual transmission was seen with IM cabotegravir. So now WHO has come out with its guidelines and it has clearly said that cabotegravir, single cabotegravir, single drug cabotegravir given IM once in 2 months is a better PrEP regimen as compared to TDF FTC oral daily tablet, and it has 80% more chance of reduction of HIV. So injectable cabotegravir given once in 2 months can take away the tablets to be taken every day for MSM population who are on PrEP. The greater efficacy of cabotegravir is likely due to better adherence, because people are more capable of taking 6 injections in a year rather than taking 365 tablets in a year. So because of better adherence, because of better efficacy, injectable cabotegravir is now going to replace TDF FTC as the PrEP regimen, not as the PEP regimen. PEP will still remain TLD, but for the PrEP regimen in HIV negative people who are at high risk of sexual transmission of HIV, their injectable cabotegravir will replace oral TDF FTC. Then there is another study, which is a post-exposure prophylaxis study. So people are now saying that not just by having condomless sex, you can get infected with HIV, but you can also get infected with other sexually transmitted infections. So not just HIV infection is more important. Now there is an increased risk of syphilis, gonorrhea, and chlamydia among people who are living with HIV or people who are engaging in risky sexual activity and are practicing condomless sex. So this study was published in NEJM, where all this population, which was people living with HIV or people who were at high risk of infection with STDs, were given 200 mg doxycycline dose after every episode of condomless sex within 72 hours. which was known as the doxy-pep study. Remember, this is post-exposure prophylaxis. Doxycycline 200 milligram was given after having condomless sexual intercourse within 72 hours, 200 milligram single dose. And what they found was there was a 55% reduction in gonorrhea, 80% reduction in chlamydia, and almost 60 to 65% reduction in syphilis, new syphilis diagnosis once you use doxycycline. So it was helpful in people living with HIV, and it was also helpful in people engaging who were HIV negative, but engaging in high risk sexual activity. So now, hopefully in the future, doxycycline post-exposure prophylaxis will be available for bacterial STIs, while TLD will be a good post-exposure prophylaxis regimen for people who are scared of acquiring HIV post-condomless sex. So doxypep's trial also showed that doxycycline 200 milligram single dose after every act of condomless sex helps in prevention of gonorrhea, syphilis, and chlamydia amongst people living with HIV. What is the new update about prevention of cardiovascular disease? You all know that now patients are on antiretroviral therapy for almost 10 years, 20 years, and the risk of cardiovascular, cerebrovascular, peripheral vascular disease is almost double in HIV positive population as compared to HIV negative population. And as the population is aging, more and more cardiovascular disease is being seen amongst HIV positive population. So this study was published in NEJM just 2 months back, and it was done in the West and in population who were 40 to 75 years of age, who were HIV positive, who were on antiretroviral therapy, and who were suppressed on antiretroviral therapy. In such a population who had a low to moderate risk of cardiovascular disease, they gave oral pitavastatin for almost 5 years. This population was followed up, and they found that by giving oral pitavastatin to this population of people living with HIV suppressed on antiretroviral therapy with a good CD4 count, 40 to 75 years of age, with a low to moderate risk of incident cardiovascular disease, the risk of cardiovascular illness, angina, myocardial infarction, stroke, peripheral vascular disease, all reduced by almost 35% over a span of 5 years. So pitavastatin does work, statins do work, and not just by reduction of LDL, but also by reducing the inflammatory markers. So we all know that statins not just have a lipid lowering activity, they also have an anti-inflammatory activity. So both these activities are working together. And now in our clinics, at least, we have started prescribing not pitavastatin because it is costly, but atorvastatin, which is now the lipid lowering agent, which is cheaply available all over India, to all patients who are 40 to 75 years of age, who are on antiretroviral therapy for a very long time, and who have a low to moderate cardiovascular risk. They should be given statins. Statins should now become the mainstay of treatment for long-term therapy along with antiretroviral therapy. So if you are a smoker, if you have a high cholesterol, if you have a high CD4 count, you have a suppressed viral load, this pitavastatin definitely works. And you look here, in Southeast Asian population, the efficacy of pitavastatin or statins is far, far more than even blacks and in Caucasian population. So especially in Southeast Asia, in Indian population, I am sure in patients who are middle-aged, who are on long-term antiretroviral therapy, who have a high LDL, giving pitavastatin will reduce incident cardiovascular, cerebrovascular, and peripheral vascular illness by almost 35% over a period of 5 years. Is there anything new about HIV TB co-infection? Yes, there is new about HIV TB co-infection. This was the study which was published, Radiant TB study, which was published in Lancet, where they compared whether giving double dose dolutegravir is really needed when you give rifampicin-based antitubercular therapy for patients with HIV TB co-infection. And they found that even if you give single dose dolutegravir, that means instead of normally we give TLD plus additional dose of dolutegravir, when you use 4-drug rifampicin-based antitubercular therapy, the virologic suppression was similar, even if you don't give the double dose dolutegravir. So initially we were taught that when you use rifampicin along with dolutegravir, double the dose of dolutegravir to 100 milligram per day. But this study, which was published in Lancet just 15 days back, shows that even with 50 milligram dolutegravir, without doubling the dose of dolutegravir, along with rifampicin, the virologic suppression remains the same. 83% suppression in HIV-TB co-infected population at 24 weeks and 48 weeks was maintained. So maybe in the future, these guidelines will also change. Just like we used to use tenofovir, lamivudine, efavirenz 600 milligram without increasing the dose with rifampicin, maybe very soon we will have TLD with no increase or no doubling of doses of dolutegravir when you use rifampicin-based antitubercular therapy in HIV-TB co-infected population. Coming to the last few slides, how will multi-drug resistant HIV treatment look like? And there is also a lot of hope in that regard because there are now new drugs available. One of them is fostemsavir, which is an attachment inhibitor. It goes and attaches to the GP120 of the virus and prevents it from attacking the CD4 of the CD4 T helper cell. And it has been found that in patients who had multi-drug resistant HIV, where there was resistance to even integrase and protease inhibitors, giving fostemsavir with optimized background regimen have almost 50 to 60% of multi-drug resistant HIV infections were suppressed. We also have ibalizumab, which is a monoclonal antibody against CD4. It goes and attaches to the CD4 helper cell and prevents HIV from attacking the CD4 cell, because of which it can be used in multi-drug resistant HIV infection. When used with optimized background regimen, this also suppresses the viral load in almost 50 to 60% of patients. So even if you fail second line, even if you fail dolutegravir, even if you have resistance to integrase inhibitors, you have resistance to protease inhibitors, and then you have a population where no other drug is going to work, constructing an optimized background regimen with fostemsavir, ibalizumab, and one more drug, which is lenacapavir, which is a capsid inhibitor, we can achieve virologic suppression even in 60% of patients who have multi-drug resistant HIV. So, although dolutegravir is now the dada drug in HIV, although darunavir, ritonavir is a very good counterpart for resistant HIV, even if you are multi-drug resistant, where you have some amount of resistance to dolutegravir, partial resistance to darunavir, there are still drugs like fostemsavir, lenacapavir, ibalizumab, which will still work. And the advantage of lenacapavir, it is subcut every 6 months. So you can see we are now moving towards long-acting injectable therapies for even treatment patients who are failing treatment and patients with multi-drug resistant HIV as well. Is there any hope about HIV cure? This was the 6th patient of HIV cure, which was published at IAS 2023 in July in Brisbane. And why was it different? Because in this case, normally we always say that we have to do a hematopoietic stem cell transplant with a delta 35 mutation. Why? Because this delta 35 mutation prevents HIV from attacking the body cells. But this was the first case where they used wild type CCR5 inhibitors, where there was no delta 35 mutation. They went ahead in this patient because he had a sarcoma. He was going to die. So they did a hematopoietic stem cell transplant for him. This hematopoietic stem cell transplant he got from a donor who was not having a delta CCR5 mutation, delta 35 mutation. And still, after 18 months, the patient could stop his antiretroviral therapy and is now antiretroviral free, while the viral load is undetectable after 18 months of hematopoietic stem cell transplant. A note of caution, such hematopoietic transplants where the delta 35 mutation was not there have failed in the past. So we need to look at it with some amount of skepticism. But yes, this has been shown as a 6th case where CCR5 donor cells were used, wild type CCR5 donor cells were used to treat biphenotypic sarcoma. The donor did not have a delta 35 mutation, and still the HIV could not enter the stem cells and could not infect the body, and the patient is seen as a functional cure, not a sterilizing cure, but functional cure. So where are we with cure strategies? As I said, 5 people have achieved sterilizing cure. All of them have received a homozygous delta 32 mutation. The 6th case, which was published at IAS, has a wild type mutation. It does not have a delta 32 mutation. So maybe there is hope by just doing a hematogenic stem cell transplant as well. There are elite controllers, there are viremic non-progressors, there are post-treatment controllers as well. But the cure still eludes us. The HIV vaccine trials have been disappointing, and we have not had a good prophylactic or a therapeutic vaccine as yet. We are trying the kick and kill strategy. We are also looking at CAR T cell therapy, but HIV cure strategies are still in their infancy. There is no clear-cut cure, but yes, 6 cases have been achieving sterilizing cure for HIV, but there are just 6 in almost 3 crore. So you can see how rare it has been. So in conclusion, the future of first-line antiretroviral therapy regimen belongs to maintenance therapy with long-acting integrase inhibitor-based injectable regimen or dolutegravir-based dual therapies. If you are failing and if you are multi-drug resistant, Lenacapavir, Ibalizumab, and Fostemsavir are there in the horizon. And once the patient fails dolutegravir or darunavir, you can still use these drugs. Injectable PrEP scores over oral PrEP and it will replace it in the future. And despite multiple success stories regarding sterilizing or therapeutic cure, a cure for everyone still eludes us. Thank you, and I'll take whatever questions come my way.
Thank you so much, sir. Thank you for such an enriching talk that you have provided with your presentation and the way you have explained the topic so well with all the questions provided. Thank you so much for that. We have received few questions from the participants. With all your due permission, I would like to put across those questions to you.
Yeah.
The first question is, what strategies have you found effective in educating patients about their infectious disease, particularly in the context of chronic conditions like HIV?
Yeah. So, see, it is very clear that we have changed HIV from a sure shot killer to a long term manageable illness. So, I always tell my patients in the OPD that today HIV has become like diabetes or blood pressure or cardiac illness. Today, I fear diabetes more than HIV because I have shown data now that a HIV positive person on long term antiretroviral therapy, if he has an adherence of more than 95%, can survive decades. He can actually have a normal lifespan, just like an HIV negative person. A diabetic person does not have that luxury. So I keep telling my patients that the drugs are very important. As of now, taking one pill once a day is the best choice, but maybe once in 2 months injections are coming so that you will become tablet free and you will have an injection to be taken for the rest of your life. A cure is at least 10 years away. So you have to keep taking these drugs. If you keep taking these drugs, you will never reach a hospital, you will never get admitted, and you will be fit and fine. And once this counseling is done regularly, we have seen that the adherence to the drug improves. The side effects of these drugs are very minimal. So more and more patients are now adhering to these regimens and the success rates are improving.
Thank you so much, sir, for answering that question. We have received another question from one of our viewers. I will take up that question. And the question is, how has telemedicine impacted the delivery of care for patients with infectious disease, including those with HIV, sir?
See, telemedicine as a concept came into being during the COVID pandemic when the patients could not reach us but needed advice from us. And we have used telemedicine extensively. We have had WhatsApp calls, we have had Zoom calls, and the patients have discussed a lot of treatments on the web, and we have tried to address these issues right away. And this has led to improvement in adherence, led to improvement in treatment, led to mitigation of side effects. And telemedicine is the future because, as you know, HIV is a disease of migrant workers who travel long distances. Single male migrants, truckers, prostitutes, men who have sex with men are the high risk categories where HIV is seen. And all these people travel a lot. So, telemedicine is the future of HIV medicine. And we should all wholeheartedly approve it because talking to our patients, understanding their problems, understanding their side effects, changing their therapy is the key to maintaining long-term virologic suppression and to stop the AIDS epidemic in its track.
Thank you so much, sir, for answering that question for our audience. Moving to the next question. The next question is, What are the challenges in providing long term care for patients living with HIV, and how has the approach to long term management evolved?
Yeah. So I have already mentioned some issues in my slides, that we are gradually now moving from a daily tablet existence to maybe a once in 2 months injection kind of an existence. So that will sort out a lot of issues with pill fatigue. Many of my patients today come and talk about treatment fatigue or pill fatigue, that how long should I keep taking this treatment? I'm already 10-15 years on treatment. I am suppressed. I have no issues. I have no side effects. I do all my jobs regularly. Should I stop treatment for a short amount of time? The answer is clearly no. We can't stop treatment, because treatment interruption studies have clearly shown that once you stop treatment, there is immediate rise in viral load. There is immediate increase, not just in opportunistic infections like tuberculosis, but non-opportunistic illnesses like cardiovascular disease. So we need to keep telling these patients that do not stop your therapy, do not take short-term interruptions, because if you take the interruptions, you might just have a heart attack, you can have a stroke, you can have a lymphoma, you can have a tuberculosis. So keep motivating them to keep on going is the most challenging factor. The second most challenging factor is now comorbidities. Many of my patients today have become diabetic, hypertensive, they have heart issues, they have kidney issues. Many patients develop chronic kidney disease, high creatinine, weak bones, fractures, fragility fractures, dementia, liver failure, or cirrhosis. All these are the general medicine topics which now patients are coming out with. So not just are we managing HIV, not just are we managing infectious diseases, but we are also managing general medicine conditions like diabetes, hypertension, heart failure, myocardial infarction, chronic obstructive pulmonary disease, addiction related problems like smoking related COPD, alcohol related cirrhosis, liver cirrhosis, acute kidney injury, fragility fractures, osteopenia, osteoporosis, bone pain, dementia, and managing these issues also are the key to improve the lifespan of the patient and improve the quality of life of patients. So the quantity we have improved, the quality we are still trying to improve, and that's why I showed the pitavastatin study, where giving pitavastatin actually reduced cerebrovascular disease, actually reduced cardiovascular disease among patients. So this is very, very important. Quality of life is also very, very important. And finally, patients are looking forward towards cure, and when the cure is going to come. So that is at least a decade away, and we have to keep motivating these patients to keep taking treatment lifelong. Many of my patients who have developed chronic kidney disease, chronic liver disease, are now getting eligible for transplants, and then transplant comes into thing. The transplant infectious diseases come on board. So now the things are becoming more and more challenging. The antiretroviral therapy is the easiest part now. Managing opportunistic infections, managing comorbidities, managing non-infectious issues, and managing lifestyle related issues have now become the most challenging aspects of HIV management today.
Thank you so much, sir, for answering that question. We will take the next question and the last question for today's session. And the question is, what lessons from managing HIV can be applied to new or emerging infectious threats?
Uh, there are many things which can be applied. Number one is, if you see, hepatitis B is more or less a similar illness like HIV. It is also a DNA virus. It also goes and attacks the DNA. It also cannot be eradicated as of now. Complete cure for hepatitis B also is quite a few years away. So we can learn that just like long-term virologic suppression of HIV helps in increasing the lifespan, preventing complications for HIV positive people, giving antiviral therapy to chronic active hepatitis B patients who actually need them. That means who are HBeAg positive with more than 20,000 international units viral load, or who are HBeAg negative with more than 2,000 international units viral load. Starting them on antivirals, keeping them on antivirals, suppressing them, doing their viral loads every year, and trying to make them HBsAg negative, which only a minority will become, is a task and we are already facing that with hepatitis B population. And as I said, HIV has become more like diabetes, blood pressure. Today, even if you miss your diabetes pills for 7 days, even if you miss your hypertension pills for 7 days, there won't be much of a problem. But if you miss your HIV pills for 7 days, there is a sudden rise in viral load. You can fail that antiretroviral therapy. You might require new drugs. So adherence to treatment is more difficult for HIV as compared to even diabetes and blood pressure. So these long-term infectious diseases who require long-term therapy, like tuberculosis, multi-drug resistant tuberculosis, as of now requires treatments anywhere between 6 months to a year. There also adherence is important. Management of side effects. As you see, we manage side effects of antiretroviral therapy very, very keenly. And that has to be applied for hepatitis B also, tuberculosis also, because if the patient develops toxicity because of anti-tubercular therapy, he's going to stop that drug. Once he stops that drug, drug-resistant TB is going to come up. So adherence, safety, management of side effects, all this is very important when you manage infectious diseases where treatment goes on months together. So anything where a long-term treatment is required, even in osteomyelitis, where if you have a knee osteomyelitis or hip osteomyelitis, where you will require antibiotic therapy for almost 3 months, sometimes even 6 months. Nocardiosis, cerebral nocardiosis, where you might require treatment for a year. Adherence, management of side effects, um, response to therapy, doing regular scans, very, very important. So HIV actually has taught us a lot about management of other diseases where you also require long-term antibiotic or long-term antifungal therapy as well.
Thank you so much, sir. Thank you for answering all the questions for all our viewers and for giving us such wonderful explanation about all the questions. Thank you so much for that. With this, I would also like to thank all the participants for their ardent participation that they have shown throughout the session by staying tuned with us and putting across their questions to us. And at the outset, I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and for sharing your insights with us. So, thank you so much. With all your last comments, sir, we can conclude the session here for today.
Okay, thank you. Bye.
Thank you so much, sir.